Now we are going to discuss pancreas. So first of all, how many sphincters are there in sphincter of Oddi complex? So this question was asked in AIMS. How many sphincters are there? Sphincters in sphincter of Oddi complex. So you can see this is sphincter of Oddi complex, and what is this first sphincter? This first sphincter is superior, is the superior choledochal sphincter. Is the superior choledochal sphincter. What's the name of this second one? This is known as inferior choledochal sphincter. What's the name of this third one? This is known as sphincter ampullae. Sphincter around ampulla. This is known as sphincter ampullae. And what's the name of this fourth one? This is known as sphincter pancreaticus. Sphincter pancreaticus. So there are 4 sphincters. How many sphincters? There are 4 sphincters in sphincter of Oddi complex. After that, a question is asked, what is pancreas divisum? Very important topic. What's the pancreas divisum? Pancreas divisum. So see, it is characterized by divided drainage. So first statement, it is characterized by divided drainage. Is the most common congenital anomaly of pancreas. Is the most common congenital anomaly of pancreas. Now see, so in this case, can you see that there is duct of Santorini, that is dorsal pancreatic duct, and there is duct of Wirsung, that is known as ventral pancreatic duct, and both of these ducts are separate. It's abnormal. So here what happens, the part of pancreas which is developed from dorsal bud is drained by duct of Santorini, and the part of pancreas which is developed from ventral bud, it is being drained by the duct of Wirsung. So first question, which part of pancreas develops from dorsal bud? So from dorsal bud, which part develops? First, part of head. So here you can see part of head. Second, body and tail. Body and tail of pancreas. And from ventral bud, which part develops? First, part of head and uncinate process. So here you can see part of head, body and tail, all these things are being drained by the dorsal pancreatic duct, where into the minor papilla or accessory papilla, whereas via major papilla or ampulla, what the part of head uncinate process is being drained. Now see the development of pancreas. So if you see the development, can you see this is ventral enlarge or ventral bud, and this is dorsal enlarge or dorsal bud. What happens? There is rotation in the duodenum as well as in the ventral bud, and because of this, can you see here the dorsal enlarge and ventral enlarge comes in the close proximity. After that, you can see this is the duct of dorsal bud and this is the duct of ventral bud. Both of these are going to fuse together and they have a common opening via major papilla, and sometimes there is accessory duct of Santorini. So this is normal, but what is the abnormal? Here you can see here the part of head and uncinate process is being drained by this duct of Wirsung, and major part, can you see here, this major part of pancreas is being drained by this duct of Santorini via minor papilla. Because of this, what will happen? There is relative outflow obstruction, and because of this relative outflow obstruction, what will happen? Patient will be having recurrent attacks of acute pancreatitis. So see the problem. Major part of pancreas is drained by duct of Santorini via minor papilla and what here head and uncinate process, part of head and uncinate process. This is drained by duct of Wirsung. It's drained by duct of Wirsung via ampulla or major papilla. Because of this, what will happen? There is relative outflow obstruction, and because of this relative outflow obstruction of pancreatic secretion, what will happen? Patient will be having recurrent attacks of acute pancreatitis. So see clinical features. Recurrent attacks of acute pancreatitis. Now question, what is the investigation of choice for diagnosis? Investigation of choice for diagnosis, it's the MRCP. And what is the gold standard investigation? The gold standard investigation is the ERCP. Now what is the basic problem? This minor papilla, it is leading to relative outflow obstruction. So what we have to go for? Dorsal duct sphincterotomy. We cut the sphincter of dorsal duct, and even if after dorsal duct sphincterotomy patient is not improved, so in those cases we perform dorsal duct sphincteroplasty. So what's the management? In this case, what's the management? Is the dorsal duct sphincterotomy, dorsal duct sphincterotomy or dorsal duct sphincteroplasty. Dorsal duct sphincteroplasty. So this is how we manage the pancreas division. Next is annular pancreas. Now see what is the problem in annular pancreas. You can see there is bilobed ventral pancreatic bud. So here you can see there is bilobed, this is bilobed ventral pancreatic duct. Now what will happen after rotation? One bud is going anterior to the duodenum and another posterior to the duodenum, and after that can you see there is formation of a ring, formation of a ring of ventral pancreas. There is formation of a ring of ventral pancreas around second part of duodenum, and it leads to what? Obstruction. This is known as annular pancreas. So it is characterized by formation of ring of ventral pancreas, ring of ventral pancreas around second part of duodenum, around second part of duodenum. This is associated with Down syndrome and duodenal atresia. So annular pancreas, what are the associations? It is associated with Down's syndrome and duodenal atresia. And duodenal atresia. Now question is asked, exactly where is the obstruction? See, this is the stomach, this is the duodenum, this is the bile duct, this is the pancreatic duct, and this is the ampulla. So exactly the obstruction is proximal to ampulla, and if obstruction is proximal to ampulla, what kind of vomiting is seen? It is associated with non-bilious vomiting. So see the clinical features. In this case, obstruction is proximal to ampulla, and it leads to non-bilious vomiting. Non-bilious vomiting. Question: what is the investigation of choice for diagnosis? The investigation of choice for diagnosis is the ERCP. And what is the treatment of choice? We have two options: duodeno-duodenostomy and duodeno-jejunostomy. So which one is the treatment of choice? Treatment. This is very important question. Treatment of choice is the duodeno-duodenostomy followed by duodeno-jejunostomy. Duodeno-duodenostomy followed by duodeno-jejunostomy. Be careful, for both annular pancreas and duodenal atresia. For both annular pancreas and duodenal atresia, the treatment of choice is duodeno-duodenostomy followed by duodeno-duodenostomy followed by duodeno-jejunostomy. But in patients of superior mesenteric artery syndrome, the treatment of choice is duodeno-jejunostomy. So in patients of superior mesenteric artery syndrome, the treatment of choice is duodeno-jejunostomy. So all these are the questions which are frequently asked. After that, questions are asked about duodenal atresia. What are the differences between annular pancreas and duodenal atresia? See, the difference is that in duodenal atresia, the obstruction is distal to ampulla. So in duodenal atresia, obstruction is distal to ampulla, and that's why how to differentiate: in the patients of duodenal atresia, there is bilious vomiting. So in patients of duodenal atresia, there is bilious vomiting. So this is how we can differentiate the annular pancreas from duodenal atresia. But be careful, the treatment of choice is same in both, and that is duodeno-duodenostomy. After that, lots of questions are asked about single bubble, double bubble and triple bubble appearance. So see how these bubbles are formed. If you see this normal anatomy, this is abdomen, and in this abdomen you can see that this is stomach, this is the duodenum, this is the jejunum. Now, where is the first bubble? The first bubble is in the fundus. Where is the second bubble? Is in the first part of duodenum. And where is the third bubble? It's at DJ, duodeno-jejunal junction. Now see, whenever the obstruction is at the pylorus, like hypertrophic pyloric stenosis, we just see one bubble. So this is single bubble. Whenever obstruction is here, proximal to ampulla or distal to ampulla, this one is annular pancreas, and this one is duodenal atresia. In these two cases, we will find two bubbles, so double bubble. And when the obstruction is here, this is jejunal atresia. Jejunal atresia, we are going to find three bubbles. So see the diagram. If you see this diagram, if we find a single bubble, it is seen in hypertrophic pyloric stenosis. If we are going to find two bubbles, it is seen in first annular pancreas, and second duodenal atresia is the duodenal atresia. And if you are going to see three bubbles, this triple bubble appearance, it is seen in jejunal atresia. It's seen in jejunal atresia. Now see how these bubbles look like on X-ray. Now see this X-ray. This X-ray is of an infant, and can you see here the whole stomach is distended. So here almost whole stomach is massively distended. So how many bubbles you can see here? Single bubble. So this is single bubble, and this single bubble is seen in which condition? Hypertrophic pyloric stenosis. Now here you can see there are two bubbles. One is in the stomach and second is in the first part of duodenum. So these are the two bubbles, and these are seen in, I told you, first it is seen in annular pancreas, and it is seen in duodenal atresia. So annular pancreas and duodenal atresia. Now see this third picture. So in this case you can see that there are three bubbles. Can you see? This is one bubble, this is the second bubble, and this is the third bubble. So here you can see three bubbles. So this is triple bubble appearance, and this triple bubble, it is seen in jejunal atresia. So this is seen in jejunal atresia. So this single bubble, double bubble and triple bubble is frequently asked image based question nowadays. Now we are going to discuss very important topic, and that is acute pancreatitis. Acute pancreatitis. First of all, what's the etiology? What's the etiology of acute pancreatitis? So first question, what is the most common cause? It's the gallstones. And what is the second most common cause? It's the alcohol. So first, gallstones. Gallstones are the most common cause of acute pancreatitis. Second, alcohol. Alcohol is the second most common cause. What are the other causes? It's the blunt trauma, ERCP, hyperparathyroidism, Hyperparathyroidism leads to hypercalcemia, hypertriglyceridemia, cystic fibrosis, carcinoma pancreas, viral infections. Question is asked, which viral infections are responsible for acute pancreatitis? And the mnemonic is CME. The mnemonic is CME. Full form, cytomegalovirus, mumps, cytomegalovirus, Coxsackie, mumps, and ecovirus. After that, drugs. Now what is the basic thing about this etiology? See, anything which can obstruct the pancreatic duct, either temporarily or permanently, because of compression or obstruction, there is pancreatitis. So gallstones are going to cause obstruction or obstruction temporarily. Alcohol, there are secretions deposited in the pancreatic duct. In hyperparathyroidism, in patients of hypercalcemia, there is stone formation. In cystic fibrosis, there is deposition of seromucinous secretions. Carcinoma pancreas, compress the pancreatic duct. So all these are responsible for acute pancreatitis. Drugs, there are two kind of drugs which are definite cause and drugs which are probable cause. So see first the definite cause of acute pancreatitis. Drugs which are definite cause of acute pancreatitis. This is very, very important, frequently asked in exam, both in medicine, surgery, and it's also asked in pharma. So first, 6 mercaptopurine. 6 mercaptopurine. Second, azathioprine. Third, deoxyinosin. Fourth, citarabine. Fifth, amino salicylic acid. And sixth, tetracycline. Seventh is the pentamidine. Eighth, estrogen. Ninth, trimethoprim sulfamethoxazole. 10th, thiazide. 11th, valproate. 12th, furosemide. And 13th, metronidazole. 13th is metronidazole. Clear? So how to remember? It's very easy to remember. The mnemonic is, can you see? MAD, CAT, PET, TV, FM. So here you can see it's MAD, CAT, PET, TV, FM. So mad cat is your pet. She likes TV and FM. So this is how you can easily remember. Mad cat is your pet. She likes TV and FM. So these are the 13 drugs which are definite cause of acute pancreatitis. 2 drugs are asked which are probable cause of acute pancreatitis. So see the probable cause. And these drugs are asked in exam frequently. First of all, L-asparaginase. It is L-asparaginase. And second is acetaminophen. So this is the etiology of acute pancreatitis. Now see what are the sequence of events which are occurring in acute pancreatitis. You know that pancreas is going to release the enzymes, digestive enzymes in inactive form. Whenever we eat something, there is release of one hormone from duodenum, enterokinase, and it is going to catalyze the first step of activation of pancreatic enzymes. What's that? Conversion of chymotrypsin into trypsin. Now see what's the problem. If there is abnormal intrapancreatic activation of pancreatic enzymes, there is injury of duct and acini. And if there is injury of duct and acini, what will happen? The pancreatic enzymes will be collected into peripancreatic region, mainly in the lesser sac, and some part enters into peritoneal cavity also. Now these pancreatic enzymes are going to digest the fat of greater omentum. Since there is lipase will digest the fat of greater omentum, and that's why what will happen? The fat will be converted into fatty acid and glycerol, and this free fatty acid will combine with calcium. And since free fatty acid combines with calcium, what will happen? There is chalky white deposits over the greater omentum, and that is known as saponification. It means the calcium is used up in this saponification process. So patients of acute pancreatitis are going to develop hypocalcemia. Be careful. Hypercalcemia is a risk factor for acute pancreatitis, but patients of acute pancreatitis develop what? Hypocalcemia. So see, acute pancreatitis. What's the cause? It's the abnormal intrapancreatic activation. Intrapancreatic pancreatic activation of pancreatic enzymes of pancreatic enzymes leading to injury of duct and acini. Injury of duct and acini. What is the good thing? That in majority of cases it's mild pancreatitis. So in majority of cases it's mild and self-limited, and that's why in patients who are having mild acute pancreatitis, how much is the mortality? Less than 1%. There is less than 1% mortality. But if the patient is having severe acute pancreatitis, how much is the mortality? It's 10 to 30%. So in severe acute pancreatitis, 10 to 30% mortality. One question is asked, which type of acute pancreatitis is having best prognosis? And it's the gallstone induced pancreatitis. Why? Because gallstones are not going to cause permanent change in the pancreas. And second, when we perform the lap cholecystectomy, etiology is removed. So very important point. Gallstone induced pancreatitis. It's having best prognosis. Now see the problem. In certain patients who are having severe acute pancreatitis, what is the cause of death? The cause of death within 2 weeks of hospitalization is multi-organ dysfunction syndrome. So very important question. What's the most common cause of death within 2 weeks of hospitalization? Within 2 weeks of hospitalization. And it's the MODS. What's the full form of MODS? It's the multi-organ dysfunction syndrome. And if patient is going to survive, patient is hospitalized for more than 2 weeks. So after 2 weeks of hospitalization, and that is sepsis. So within 2 weeks of hospitalization is the multi-organ dysfunction syndrome. After 2 weeks of hospitalization, it's the sepsis. Now see the problem. In multi-organ dysfunction syndrome, what's the initial sign? Patient is having impaired lung function. Why? Because of ARDS. So what is the initial sign? Initial sign of MODS is the impaired lung function. Impaired lung function because of ARDS, adult respiratory distress syndrome. So these are the questions which are commonly asked about acute pancreatitis. Now see, mainly the pancreas is located on the left side of abdomen. So what are the clinical features? There is pain in epigastrium, radiating to left side of back, partially relieved by sitting and bending forward. So partially relieved by sitting and bending forward. Second, these patients are also having paralytic ileus. So these patients are having paralytic ileus. And because of paralytic ileus, what are the manifestations? Patients are having nausea, vomiting, and abdominal distension. abdominal distension. Now what is the problem? Because of paralytic ileus, the signs are seen on X-ray. So if we are going for X-ray abdomen, the signs of paralytic ileus are seen. So what are those signs? These are frequently asked signs in exam. First, there is gasless abdomen. There is gasless abdomen. There is ground glass appearance. Ground glass appearance. There is localized ileus of jejunum known as sentinel loop. Localized ileus of jejunum is the sentinel loop, and there is colon cutoff sign. There is colon cutoff sign. How it looks like? So in this picture, what you can see this part of transverse colon, but what you cannot see the colon beyond this splenic flexure. So this is colon cutoff sign. So these are important signs seen. After that, one question is asked: pancreas in acute pancreatitis, on which side there is pleural effusion? Since the pancreas is mainly located on left side, it is associated with left-sided pleural effusion. So there is left-sided pleural effusion. After that, there is one rare manifestation of acute pancreatitis is there, and that is what? Hemorrhage. So hemorrhage is one of the rare manifestation, but what? It's commonly asked. So see, what are the various signs seen in hemorrhagic pancreatitis? So in hemorrhagic pancreatitis, what are the problems? See, if this is abdomen, there is ecchymosis around umbilicus, and that is known as Cullen sign. So what is this Cullen sign? It's the ecchymosis around umbilicus. After that, there is ecchymosis around the flank. Ecchymosis around the flank. This is known as Gray-Turner sign. It's known as Gray-Turner sign. And this is ecchymosis around flank. Ecchymosis around flank. After that, there is ecchymosis around inguinal region. This is known as Fox sign. Fox sign. This is ecchymosis around inguinal region. Ecchymosis around inguinal region. Now see how it looks like. Here you can see that there is ecchymosis around umbilicus, and this is known as what? Cullen sign. Here you can see that there is ecchymosis around the flank. This is Gray-Turner sign. And in this picture you can see that there is ecchymosis around the flank. So this is Gray-Turner, and ecchymosis around inguinal region. So this is Fox sign. So this is Fox sign, and this is what? Gray-Turner sign. Gray-Turner sign. So these are important signs which are asked in exam. Question is asked: what is the investigation of choice for diagnosis of acute pancreatitis? Very important question. Investigation of choice for diagnosis of acute pancreatitis. It is CCT. So second question is asked: what is the best time to perform CT in acute pancreatitis? Best time to perform CT in acute pancreatitis. It's after 3 days. After 3 days. This is the question. Now question, why after 3 days? Because most of the complications of acute pancreatitis are going to occur after 3 days. Why we are doing CCT in patients of acute pancreatitis? Mainly for diagnosis of the complications. Otherwise, we are going to make the diagnosis of acute pancreatitis on the basis of clinical findings and laboratory investigations. So second important point, usually the diagnosis is made by clinical findings and laboratory investigations. Clinical findings and laboratory investigations. Which investigations? First, amylase. So what? Amylase is raised. But what is the problem? The amylase is not very specific because it can be raised in non-pancreatic causes. And second, there is no correlation between the level of amylase and severity of acute pancreatitis. In some patients of mild acute pancreatitis, the level is very high, and in patients having necrotizing pancreatitis or pancreatic necrosis, the levels might be normal. So problems, amylase. First, it can be raised in non-pancreatic causes. Can be raised in non-pancreatic causes. And second, there is no correlation between level of amylase and severity of acute pancreatitis. Level of amylase and severity of acute pancreatitis. Even in 10% patients having severe acute pancreatitis, amylase can be normal. So which one is specific investigation? Lipase. Lipase is more specific than amylase. So it's more specific. So this is how we can easily make the diagnosis of acute pancreatitis. Now, is there any role of ultrasound? See the problem. Generally, in majority of cases of acute pancreatitis, ultrasound is not very useful or helpful. Why? Because ultrasound is not a very good investigation for the organs located in retroperitoneum. Why? Because for ultrasound waves, the bone and gas is poor conductor. So whatever the organs which are located in retroperitoneum, for most of the pathologies, investigation of choice for diagnosis is CCT. So see, what are the boundaries of retroperitoneum? Boundaries of retroperitoneum. Superiorly, there is dome of diaphragm. Inferiorly, there is levator ani. Posteriorly, there is psoas muscle, and anteriorly there is peritoneum. So see the boundaries. This is dome of diaphragm, this is psoas muscle, this is levator ani, and anteriorly there is peritoneum. Now see the organs. This is C loop of duodenum and pancreas. This is IVC. This is aorta. This is kidney. This is ureter. This is adrenal, kidney, ureter, adrenal, and this is the ascending colon, and this is the descending colon. Why ascending and descending colon is dotted? Because only posterior part is retroperitoneal, anterior part is intraperitoneal. So for most of these pathologies, investigation of choice for diagnosis is CCT. So see the statement, CCT is investigation of choice for diagnosis of most of retroperitoneal pathologies. most of retroperitoneal pathologies. See the example. First, pancreas related. Pancreas related. So question, CCT is investigation of choice for diagnosis of acute pancreatitis, pancreatic pseudocyst, pancreatic abscess, pancreatic necrosis, and carcinoma pancreas. So for all these cases, the investigation of choice for diagnosis is CCT. What is the exception? See, the chronic pancreatitis. And for chronic pancreatitis, what is the investigation of choice for diagnosis? Is the MRCP. For chronic pancreatitis, investigation of choice for diagnosis is MRCP. Second is kidney related. So kidney related. Now see, CCT is investigation of choice for diagnosis of first ADPKD, adult onset or autosomal dominant polycystic kidney disease, renal tuberculosis, RCC, angiomyolipoma, and renal oncocytoma. Third, very important point, CCT is investigation of choice for diagnosis of retroperitoneal fibrosis and retroperitoneal sarcoma. Retroperitoneal fibrosis and retroperitoneal sarcoma. So now you have a rough idea that for most of the retroperitoneal pathologies, investigation of choice for diagnosis is CCT. Now coming to the management of acute pancreatitis. So see, management of acute pancreatitis. What is the cornerstone of treatment or management? Is the fluid resuscitation plus oxygenation. So the cornerstone treatment is fluid resuscitation. Question, what is the fluid of choice? The fluid of choice is ringer lactate. Is the ringer lactate. And second is what? Oxygenation. So this is the cornerstone of treatment. Simultaneously, there is pain. So for pain, we have to give analgesics. So what? Analgesics. So question, which analgesics? See, NSAID of choice. NSAID of choice is the metamizole. And what is the opiate of choice? Opiate of choice, it's buprenorphine. NSAID of choice, metamizole. Opiate of choice is buprenorphine. After that, we have to start the nutrition. So which nutrition is preferred? Generally, in acute pancreatitis, enteral nutrition is preferred over total parenteral nutrition. Question is asked, what are the indications of total parenteral nutrition? So see, the indications of total parenteral nutrition, generally in shock and in severe acute pancreatitis. Severe acute pancreatitis, we give total parenteral nutrition and and prophylactic antibiotics should not be given. In this case, prophylactic antibiotics should not be given. So if the patient is having evidence of infection, then only we give antibiotics. Otherwise, prophylactic antibiotics are not given. And this is how we manage the patients of acute pancreatitis. Now see the prognostic scoring systems in acute pancreatitis, and it's very, very important. Prognostic scoring system. Prognostic scoring system in acute pancreatitis. First is Ranson score. Ranson's score. Second is modified Glasgow score. And third is Bishop score. Ranson score, modified Glasgow score, Bishop score. In all these three, if the score is more than equal to 3, it is suggestive of severe acute pancreatitis. After that, there is Apache 2. Apache 2. How much should be the score in Apache 2? Here, more than equal to 8. If it's more than equal to 8, it is suggestive of severe acute pancreatitis. Next is QSOFA. QSOFA. Next is CT severity index. CT severity index. What are the components of CT severity index? The components are Balthazar CT grading, plus necrosis score. So Balthazar CT grading plus necrosis score and C-reactive protein more than equal to 130 milligram per ml. So C-reactive protein more than 130 milligram per ml. These prognostic scoring systems are frequently asked, especially Ranson's, Bishop, Apache 2 and QSOFA. These 4 are frequently asked. We are going to discuss one by one. First of all, Ranson's prognostic criteria. So see the Ranson's prognostic criteria. Ranson's prognostic criteria. There are 2 criteria. One is for gallstone-induced pancreatitis and second is for non-gallstone-induced pancreatitis. Which one is frequently asked in exam? It's the non-gallstone-induced pancreatitis. So see, there are 2 set of parameters. One assessed at the time of admission. Assessed at the time of admission, and second after 48 hours. Second after 48 hours. So first, age more than 55 years. Second, WBC count more than 16,000 per microliter. Third, blood sugar RBS more than 200 milligram per deciliter. And fourth, LDH more than 350 international units per liter. And fifth, AST more than 250 units per liter. 5 parameters assessed at the time of admission. Now after 48 hours, first, fall in hematocrit. Fall in hematocrit more than 10 points. Second, blood urea nitrogen elevation blood urea nitrogen elevation more than 5 milligram per deciliter. Third, serum calcium less than 8 milligram per deciliter. Fourth, base deficit more than 4 milliequivalent per liter. Fifth, arterial PO2 less than 60 mmHg, and fluid sequestration more than 6 liters. So these are total 11 parameters. Out of these 11 parameters, how many should be present so that we are going to label the patient as severe pancreatitis? That patient is having severe pancreatitis whenever the score is more than equal to 3. So if the score is more than equal to 3, we are going to label the patient as this patient is having severe acute pancreatitis. But what is the biggest problem? How much minimum time is required for complete assessment? The minimum time required is 48 hours. Sometimes we want to assess the severity of acute pancreatitis bedside. So that score is known as what? Bishop score. It is calculated bedside. It can be performed in any patients anytime. So what's the Bishop score? Now see, what's the full form? It's the bedside index for severity of acute pancreatitis. And here the parameters are also Bishop. The parameters are also Bishop. So full form, first, blood urea nitrogen more than 25 milligram per deciliter. I is the impaired mental status. SIRS. What is the full form of SIRS? Systemic inflammatory response syndrome. Now what are the parameters of systemic inflammatory response syndrome? There is a mnemonic for this systemic inflammatory response syndrome, and the mnemonic is THR counts. It's the THR counts, total heart rate counts. So what are the parameters? First, T is the temperature. How much should be the temperature? Either more than 38 degrees centigrade or less than 36 degrees centigrade. Second, heart rate more than 90 per minute. Third, respiratory rate more than 20 per minute. And fourth, WBC count either more than 12,000 per microliter or less than 4,000 per microliter, or more than 10% immature cells, more than 10% immature cells in peripheral smear. Now here you can see how many parameters are there? 4. Out of 4, if more than equal to 2 of 4 parameters are present, it is considered positive. So this is systemic inflammatory response syndrome. A, age more than 60 years, and P is pleural effusion. So here you can make out how many parameters are there? 5. Out of 5, if more than equal to 3 are present, it is suggestive of severe acute pancreatitis. Now see the mortality. If the score is 0 to 2, how much is the mortality? Less than 2%. And when the score is 3 to 5, how much is the mortality? Can you see? more than 15%. So score 0 to 2, the mortality is less than 2%, and if it's 3 to 5, it's more than 15%. It's very, very important, this Bishop score, and this is frequently asked nowadays. After that, next is Apache 2, and this is also very important. Apache 2. Question: what is the full form of Apache 2? Full form is the acute physiology, and chronic health evaluation. Chronic health evaluation 2. Acute physiology and chronic health evaluation 2. Now, what are the parameters? You can easily remember by this simple mnemonic. What? Blood transfusion increases heart rate at Commonwealth Games, sharp number 2. Blood transfusion increases heart rate at Commonwealth Games, sharp number 2. So what are the parameters? First, B, blood pressure. Second, T, temperature. Third, heart rate. Fourth, respiratory rate. Fifth, creatinine. Sixth, W, WBC count. G, Glasgow Coma Scale, and S is sodium. After that, ninth, hematocrit is the hematocrit. 10th, O, oxygenation. 11th, pH, and 12th, potassium. So how to remember? Generally, it includes the vitals and laboratory parameters. So can you see vitals? Blood pressure, temperature, heart rate, and respiratory rate. After that, laboratory investigation, creatinine, WBC count, sodium, potassium, and after that, 4 other parameters are GCS, hematocrit, oxygenation, and pH. So this is how you have to remember. Out of these 12 parameters, how many should be present? More than equal to 8, and this is suggestive of severe acute pancreatitis. So whenever it's more than equal to 8, patient is having severe acute pancreatitis. Next is very, very important. It's QSOFA. So question: what is the full form of QSOFA? It's the quick SOFA. So what is the full form of SOFA? It's the sequential organ failure assessment. Sequential organ failure assessment. So this is the full form. How to remember? The mnemonic is QRSMS. The parameters are QRSMS. So what do you mean by Q? Q means QSOFA. R means first respiratory rate. How much? More than equal to 22 per minute. S is systolic blood pressure. How much? Less than equal to 100 mmHg. And MS is mental status alteration. And each of these parameters are given a score of 1. So maximum score is how much? 3, and the minimum score is 0. So see how much is the mortality here. If the score is 0, the mortality is less than 1%. If the score is 1, the mortality is 2 to 3%. And whenever the score is more than equal to 2, the mortality is more than equal to 10%. So this is mortality, and this is the score. So it's very easy to remember this QSOFA. Mnemonic is QRSMS. So three parameters are frequently asked. One is the Apache 2, second is the Bishop, and third is the QRSMS. These are frequently asked prognostic scoring systems for acute pancreatitis. After that, questions are asked about local complications of acute pancreatitis. Questions are asked related to local complications of acute pancreatitis. So see, what are the local complications? Local complications of acute pancreatitis. It is of two types. One is acute and second is chronic. So it is further divided into acute and chronic. Acute means the duration is less than 4 weeks and there is no well-defined wall. Chronic means the duration is more than 4 weeks and there is well-defined wall. So here, duration less than 4 weeks and there is no defined wall. Whereas in chronic, the duration is more than 4 weeks and there is a defined wall. Defined wall. So see, first is acute pancreatic fluid collection. Acute pancreatic fluid collection. It is also known as APFC. Acute pancreatic fluid collection. Now see the problem. In majority of cases, this acute pancreatic fluid collection, it is reabsorbed or disappears spontaneously. But if it is going to persist for more than 4 weeks, it is lined by granulation tissue. And whenever it is walled off, lined by granulation tissue, this is known as what? Pseudocyst. So when it is lined by granulation tissue, it's known as pseudocyst. Question: what is the most common site of acute pancreatic fluid collection? It's the lesser sac, and that's why most common site of pancreatic pseudocyst is also lesser sac. Second is acute necrotic collection. It's the acute necrotic collection. So it is acute necrotic collection, and after 4 weeks, what will happen? This will be walled off, so known as walled off necrosis. Walled off necrosis. This is known as ANC in short. So acute complications are acute pancreatic fluid collection, acute necrotic collection, and when it is walled off, the fluid collection is converted into pseudocyst, and this necrotic collection, it is known as walled off necrosis. After that, how we are going to manage these complications and what are the characteristic features? Have a look. First of all, acute pancreatic fluid collection. Acute pancreatic fluid collection. So, in majority of patient, it resolves spontaneously. It resolves spontaneously in majority of cases. Otherwise, what will happen? After 4 weeks, it's converted into pancreatic pseudocyst. So after that, we will manage what? Pancreatic pseudocyst. It's a big topic. I will discuss in detail. Second is pancreatic abscess. What's the problem in pancreatic abscess? There is pus collection in peripancreatic region. So in this case, there is pus collection in peripancreatic region. In peripancreatic region. And if there is pus collection, what are the manifestations? Patient will be having pain, tenderness, fever with chills and rigor. How we are going to manage? Be careful. Here, the preferred treatment is ultrasound or CT guided percutaneous aspiration plus antibiotics. So ultrasound or CT guided percutaneous aspiration plus antibiotics. Third, which is very very important, and that's pancreatic necrosis. It's the pancreatic necrosis. It's very very important. What is pancreatic necrosis? Is the non-viable pancreas or peri-pancreatic fat. So this is non-viable pancreatic tissue. Is the non-viable pancreatic tissue or peri-pancreatic fat. Peri-pancreatic fat. So non-viable pancreatic tissue or peri-pancreatic fat. Now see, this is a sterile condition. But what is the problem? Since it is sterile, the most common complication is infection. So the most common complication is the infection. So question, if the most common complication is infection, what is the most common organism responsible? And it's the E. coli. So question, most common organism responsible, and that is E. coli. After that, generally there are no good antibiotics for pancreas which are having good pancreatic penetration except one group, and that group is what? Carbapenems, imipenem and meropenem. So what's the group of antibiotic having good pancreatic penetration? Is the carbapenems. One is imipenem, and second is meropenem. Now what is the problem? Since there is necrosed pancreatic tissue, we have to excise that necrosed material, and that is known as what? Necrosectomy. Problem, after every 3 to 4 days further necrosis is going to occur. So what we have to go for? Again we have to go for necrosectomy. So this is known as what? Repeated necrosectomy, also known as repeated surgical debridement. So how we are going to manage this condition? Management, we go for repeated necrosectomy or surgical debridement with ongoing lavage. So this is how we are going to manage the pancreatic necrosis. Now very important topic, that is pancreatic pseudocyst. First question, is the most common cystic lesion of pancreas? So it's the most common cystic lesion of pancreas. So it's the most common cystic lesion of pancreas. First question. Second, can you see the name is pseudocyst? Is the pseudocyst means it's the false cyst. So second, it's the false cyst. It's lined by, why it's false cyst? Because it's lined by granulation tissue. Generally, true cyst is lined by epithelium. So it's not lined by epithelium. So that's why it's false cyst, and actually speaking, it is lined by granulation tissue. Question, what's the most common cause of pseudocyst? The most common cause is alcohol. Be careful, it's alcohol. What's the most common site? We already discussed. The most common site is what? Lesser sac. The most common site is lesser sac. Most common cause is alcohol. Most common site is lesser sac. It is seen in both acute and chronic pancreatitis. Now see what's the difference. In acute pancreatitis, what's the problem? And in chronic pancreatitis, what's the problem? So acute pancreatitis and chronic pancreatitis. Generally in acute pancreatitis, it's single, it's large and extra pancreatic. and extra pancreatic. And in chronic pancreatitis, it's generally multiple, small, and intrapancreatic. One question is asked frequently that how much is the incidence? If you see in acute pancreatitis, it's 10 to 20%, and in chronic pancreatitis, it's 20 to 40%. So in acute pancreatitis, 10 to 20%, chronic pancreatitis, 20 to 40%. So this is the incidence. After that, what is the location? What is the presentation? Have a look. Now just have a look of the relation of cyst and the organs. Can you see what's this organ? This is the stomach, right? What is this organ? This is the liver. What is this organ? This is the spleen. What is this? This is the right kidney. What is this? This is the aorta. Now can you see this organ is what? This is the pancreas. And in the pancreas, what's the problem? There is the cyst. Now if you see the relation of cyst, with stomach, now see, just focus. This is the stomach and this is the cyst. Now in majority of patients, what's the problem? In majority of patients, the cyst is very small, and if the cyst is very small, there is no symptom at all. So most patients are asymptomatic. But if cyst is large, what is the most common symptom? There is abdominal pain. Simultaneously, can you see this is the anterior wall of cyst? It is going to compress the posterior wall. So what will happen? The anterior and posterior wall of stomach is going to collapse, and it is going to push this stomach towards abdominal wall. That's why whenever patient is going to eat something, drink something, after meals, what happens? There is vomiting. What kind of? Non-bilious vomiting. So clinical features. Most patients are asymptomatic. Most patients are asymptomatic. Now see, in symptomatic patients, the most common symptom is abdominal pain. The most common symptom is abdominal pain. What's the other symptom? There is symptom of gastric outlet obstruction, like there is non-bilious vomiting, non-bilious vomiting containing undigested food particles, right? After that, questions are asked, what are the complications of pseudocyst? So see the complications of pseudocyst. First, most common complication, it's the infection seen in 14% patients, followed by hemorrhage in 10% patients. Question is asked, what's the investigation of choice for diagnosis of pseudocyst? I told you, for most of acute pancreatitis related complications, investigation of choice for diagnosis is CCT. So here also, investigation of choice for diagnosis is the CCT. Diagnosis is done. After that, treatment. See, in majority of cases, the size of cyst is small and it disappears spontaneously. So, what is done? Only observation. So, we have to go for observation only. Why? Because most pseudocysts disappear. So question, what are the indications of surgery if cyst is going to persist? For what duration? More than 6 weeks. So question, what are the indications indications of surgery. Whenever first the duration is more than 6 weeks, or second, size more than equal to 6 centimeter. So in these cases we have to go for surgical intervention. And what are the treatment options? The treatment options are cystogastrostomy is the cystogastrostomy. Second, cystoduodenostomy, and third is cystojejunostomy. It's a cystojejunostomy. Two questions are asked. Out of these three, which one is the most popular, easy to perform? Most popular and easy to perform is the cystogastrostomy. And which one is the treatment of choice? The treatment of choice is cystojejunostomy. Why? Have a look. Now see this CT again. You can see what? This is the stomach. This is the anterior wall of stomach. This is the posterior wall of stomach. And can you see this is the cyst? And in this cyst, this is the anterior wall of cyst and this is the posterior wall of the cyst. Now what I'm going to do, can you see? I will open, after laparotomy, I'm going to open the anterior wall of stomach. After opening anterior wall of stomach, I'm going to open what? Posterior wall of stomach. So I open this posterior wall of stomach. After that, I'm going to open this anterior wall of cyst. After opening anterior wall of cyst, I take the biopsy from cyst wall. Why? To rule out malignancy. After that, can you see? I will suture the anterior wall of cyst to posterior wall of stomach. So I suture anterior wall of cyst to posterior wall of stomach. And after surgery, I close this anterior wall of stomach. What will happen? Whatever the secretions are there, can you see? The secretions, all these secretions of this cyst or collection start going into stomach. So what's the name of this surgery? Here you can see the cyst is having opening or mouth in the stomach. So this is known as what? Cystogastrostomy. So how we perform it? Have a look. And in this case, one problem will be there. This drainage is against gravity. That's why it will take time for the cyst to collapse, and sometimes what happens, the food substances might collect in the cyst, and if the food is going to collect in the cyst after meals, what will happen? There is bacterial overgrowth and this is known as sump syndrome. So see the problems. This is the stomach, this is the duodenum, and here you can see this is the cyst. I'm going to perform cystogastrostomy, communication between cyst and stomach, and after that what happens? The cyst contents start going into the stomach. So this is cystogastrostomy. It's the cystogastrostomy. Problem, what are the disadvantages? First, the drainage is against gravity. Drainage against gravity, and there is sump syndrome. What is this sump syndrome? It's the bacterial overgrowth after food collection in the cyst. Bacterial overgrowth after food collection in cyst. So this is the problem. So this is cystogastrostomy disadvantages. After that, why cystojejunostomy is the treatment of choice? It's Roux and Y cystojejunostomy. So first I am going to tell you how to make Roux and Y. See, this is the stomach, this is the duodenum, and this is the jejunum. I'm going to divide the jejunum. After dividing jejunum, you can see this is the proximal part of jejunum and this is the distal part of jejunum. I take this distal part of jejunum up. After that, the diagram is something like this. This is the proximal part of jejunum and this is the distal part of jejunum. So I restore the continuity between proximal and distal part. How can you see? Like this. So this is jejunostomy. What kind of end to side jejunostomy? Can you see? This is looking like Y. So this is Y limb and this is the free limb. That's the root limb. What's the distance or length of this root limb? It can vary from 40 to 100. It can vary from 40 to 100 centimeter. On an average, it's 50 to 60 centimeter. So this is Ru and Y reconstruction. If I suture this Ru limb to stomach, it becomes Ru and Y gastrojejunostomy. If I suture this to hepatic duct, it becomes hepaticojejunostomy. And if I'm going to suture this to the cyst, it becomes Ru and Y cystojejunostomy. See? So here you can see this is what stomach, this is what duodenum and jejunum, Y limb, and this is what the Ru limb. And can you see this is what? This is the cyst. And there is a communication between cyst and jejunum. So what will happen? The cyst contents start going into jejunum. So what's the name? It's Ru and Y cystojejunostomy. So it's Ru and Y cystojejunostomy. It's the treatment of choice. What's the advantage? Can you see here the drainage along gravity? So there is drainage along gravity and no sump syndrome is seen. No sump syndrome. But what is the disadvantage? Here you can see two anastomosis are made. One is jejunostomy and second is cystojejunostomy. And in surgery, the duration of surgery is directly proportional to number of anastomosis and amount of blood loss is directly proportional to duration of surgery. So what is the disadvantage? Disadvantage is that there is increased duration, and since there is increased duration, there is increased blood loss. So there is increased duration and increased blood loss. Now see the mutations associated with clinical pancreatic syndromes. First of all, what is the mutation associated with hereditary pancreatitis? With hereditary pancreatitis, the most common mutation, the mutation associated with PRSS1. It is also known as cationic trypsinogen gene. So it's PRSS1, also known as cationic trypsinogen gene. This is first. After that, second one is idiopathic chronic pancreatitis. Idiopathic chronic pancreatitis. And what's the gene mutated? This is the gene mutated is CFTR. It's the CFTR. And the third is tropical calcific pancreatitis. Tropical calcific pancreatitis. So tropical calcific pancreatitis. And the gene mutated is SPINK1. This is SPINK1, also known as PTSI. So SPINK1 or PTSI. So these are the three questions which are asked related to mutations in the patients of chronic pancreatitis. Now in detail, we are going to discuss the chronic pancreatitis. Chronic pancreatitis is characterized by irreversible fibrosis of pancreatic parenchyma with ongoing inflammation, and it leads to exocrine and endocrine insufficiency. So see, it is characterized by irreversible fibrosis. Be careful, it's irreversible. Irreversible fibrosis of pancreatic parenchyma. Of pancreatic parenchyma with ongoing inflammation. So there is ongoing inflammation, and because of this, what's the problem? There is exocrine insufficiency, endocrine insufficiency, and there is chronic pain. So there are three problems. There is exocrine insufficiency, there is endocrine insufficiency, and there is chronic pain. So first question, which one precedes? Be careful, exocrine insufficiency precedes endocrine insufficiency. So first question, exocrine insufficiency, it precedes endocrine insufficiency. After that, second question, how much acini and how much islet cells are permanently destroyed to develop exocrine and endocrine insufficiency? So see, when more than 90% of acini and more than 90% of islet cells are permanently destroyed. These are permanently destroyed. Then only patient is going to develop what? Exocrine and endocrine insufficiency. After that, what are the manifestations of exocrine insufficiency? The exocrine secretions are responsible for digestion. So what is the problem? Here, there is indigestion. So if there is indigestion, what's the problem? There is malabsorption. And if there is malabsorption of fat, there is fecal fat more than 7 grams per day. So what will happen? There is steatorrhea. There is steatorrhea, means the fecal fat is more than 7 grams per day. So fecal fat is more than 7 grams per day. This is exocrine insufficiency. What happens in endocrine insufficiency? Patient is having diabetes mellitus, and obviously patients are having chronic pain. Question is asked, what's the most common cause of chronic pancreatitis? Is the heavy alcohol consumption. So see the causes. Most common cause is the heavy alcohol consumption. Second question, it's not only alcohol which is responsible. There are certain synergistic factors or environmental factors which are having synergistic effect with alcohol, and one of such environmental factor is smoking. Is the smoking. So smoking is having synergistic effect. It's having synergistic effect. There is one classification system which is very important and frequently asked in relation to chronic pancreatitis, and it's related to etiology. What's the name of classification? It's known as Tigard-O. It's known as Tigard-O classification. So what is this Tigard-O classification? See, T means toxic metabolic, like alcohol is a toxin. I, idiopathic, is the idiopathic. G is the genetic. A, autoimmune, autoimmune. R, recurrent severe, it's the recurrent severe. And O, that's obstructive. O is obstructive. It's O, obstructive. So this is Tigaro classification for chronic pancreatitis. After that, what are the clinical features? First question, what's the most common symptom? The most common symptom of chronic pancreatitis is the abdominal pain. Is the abdominal pain. Second question, chronic pancreatitis is characterized by a triad. It's characterized by a triad. What's the mnemonic? How to remember? Mnemonic is DPS. It's the DPS. So what's the meaning of D? D means diabetes mellitus. P means pancreatic calcification. And S means steatorrhea. Pancreatic calcification, S means steatorrhea. Now can you see in the triad, you can see that this is exocrine insufficiency, diabetes mellitus is endocrine insufficiency, and there is permanent change associated with pancreas. What? Pancreatic calcification. Now what is the problem in chronic pancreatitis? There is formation of multiple strictures in the pancreatic duct, and there is formation of stones. And what's the composition of stone? It's the calcium carbonate. Now have a look. This is the pancreas, and in the pancreas, can you see this is the duct? So this is the pancreatic duct. In this pancreatic duct, what is the problem? There is stone. What's the composition of this stone? It's the calcium carbonate. Calcium carbonate. And can you see what's the problem in the duct? There is stricture, dilatation, stricture, dilatation. So on ERCP, what is the name of this appearance? This is chain of lakes. This is known as chain of lakes appearance, also known as string of pearls appearance. Chain of lakes appearance, string of pearls appearance. And what is the composition of stone? Composition of stone is the calcium carbonate. The composition of stone is calcium carbonate. So these are the changes seen in pancreatic duct and the pancreas. Now questions are asked about the investigations. So see how we are going to diagnose the chronic pancreatitis. If we perform X-ray, in how many cases the calcification is seen? In chronic pancreatitis, there is calcification. Calcification is seen in 30 to 40% patients. This calcification can be seen on X-ray also, and it's better appreciated on CT. See the finding? So here you can easily make out, here in this pancreas, you can easily make out that there is calcification. Clear? So this is the calcification. Sometimes they give you plain X-ray abdomen and they are going to ask you what's the diagnosis. See this X-ray? So if you see this X-ray, can you see here? If you see this X-ray, you can notice that there is evidence of stone in this region. So you can notice that there is evidence of stone. And what is this stone? Actually, it is in relation to or in association with chronic pancreatitis. Now comes the question. Whatever the permanent changes are there in the duct, usually investigation of choice for diagnosis is what? MRCP. So here also investigation of choice for diagnosis is MRCP. So very important point, investigation of choice for diagnosis of chronic pancreatitis, and that is MRCP. This is one question. Second, you noticed that in chronic pancreatitis there is stone and there is stricture. That's why gold standard investigation for chronic pancreatitis, and that is ERCP. Why? Because we can remove the stone and we can relieve the obstruction. Now see the finding. So here you can see this is the finding in chronic pancreatitis on ERCP. Can you see? So what kind of a appearance is there? In the duct you can see this is the kind of appearance. So what's the name of this appearance? This is string of pearls or chain of flakes appearance on ERCP. Third, minimal change chronic pancreatitis or early changes in chronic pancreatitis are best diagnosed by endoscopic ultrasound. So very important point, endoscopic ultrasound is the most accurate. It's most accurate for detection of minimal changes or minimal change chronic pancreatitis. In this, what happens? The changes are limited to minor ducts only, and there is a criteria. What's the name of criteria? Is the Rosemont criteria. Rosemont criteria. It's based on endoscopic ultrasound findings for diagnosis of chronic pancreatitis. So Rosemont criteria is based on endoscopic ultrasound findings for diagnosis of chronic pancreatitis. When the diagnosis is done, we have to start the management. Now see the problem. There are three main problems. One, exocrine insufficiency. So we have to give what? Pancreatic enzyme supplements. Endocrine insufficiency. So we have to start insulin, and there is pain. We have to give analgesics. So see the management. First, for exocrine insufficiency. For exocrine insufficiency, what we have to start? Enteric coated pancreatic enzyme supplements. Pancreatic enzyme supplements. So enteric coated pancreatic enzyme supplements. After that, for endocrine insufficiency, what we have to start? We have to give insulin. So since patient is having diabetes, we have to start insulin. And after that, for pain, initially what we have to start? Analgesics. We have to start initially analgesics. Question, what is the NSAID of choice? NSAID, we give metamizole. Just like acute pancreatitis. And opiate, we give buprenorphine. Opiate is buprenorphine. Now see, in some patients, pain is still there. It's not completely relieved. And when pain is not relieved, one theory is responsible for this pain. And what that theory says is the ductal hypertension which is responsible for the pain. What do you mean by ductal hypertension? Means increased pressure in the duct because of strictures or the stone. So if you relieve the stricture, means obstruction, by putting a stent, or if you relieve the obstruction by removing the stone by ERCP, pain is relieved. So see, there is no improvement or still pain persists. In that case, we go for ERCP with stenting. Oblique stone removal. Even after this, if there is no improvement or pain persists, after that we go for celiac ganglia block. Celiac ganglia block. And if there is incomplete relief, last step is what? We have surgical intervention. We have surgical intervention for pain relief. So there are two kinds of surgery available. One is drainage procedure and one is resection procedure. This drainage procedure works on the principle of ductal hypertension. So what? It's the ductal hypertension which is responsible for pain. So if we relieve the obstruction, if we drain the duct freely, pain is relieved. And resection procedure works on the principle of what? Pancreatic head. Is the pancreatic head, which is the pacemaker of inflammation. Is the pacemaker of inflammation. It means in the resection procedure we have to excise the pancreatic head. So see, what are the two procedures? One is drainage procedure and second is resection procedure. So drainage procedure and resection procedure. Now see, this drainage procedure generally we perform here Pusto procedure. What we perform? We perform Pusto procedure. And what's the name of this procedure? In short, known as LPJ. And what is the full form? It's the longitudinal pancreatico jejunostomy. So it's the longitudinal pancreatico jejunostomy. In resection procedures, there are two procedures. First is Beger's procedure. What is the other name of Beger's procedure? It's also known as DPPHR. In short, DPPHR full form, it's duodenal preserving pancreatic head resection. It's duodenal preserving pancreatic head resection. And second is Fraze procedure. Fraze procedure, in short, is known as LRLPJ. In short, it's known as LRLPJ. So full form is the local resection. Is the local resection of pancreatic head with longitudinal pancreatico jejunostomy. With longitudinal pancreatico jejunostomy. So these are the commonly asked questions. Now how we are going to perform these procedures? Have a look. Now here you can see what we are going to do. Can you see this duct is dilated and this duct is having stones also. So I'm going to open the duct along its whole length. So the duct is being opened, and after that can you see this jejunum? I'm going to suture what? Jejunum. So I perform the anastomosis between the jejunum and whole length of pancreatic duct. So what's the name of this anastomosis? Longitudinal pancreatico jejunostomy. So you can see here that how we are going to perform this longitudinal pancreatico jejunostomy. And what's the name of this procedure? This is known as what? Pusto's procedure. It is Pusto's procedure. Now see here what is being done. Here you can see this is the part of head. So this is the part of head. So this is pancreatic head. So this pancreatic head is being dissected. So after resecting this pancreatic head, what I'm going to do? I'm going to restore the continuity. Can you see? This is the pancreatic duct and this is the jejunum. So I'm going to restore the continuity with end-to-end pancreatico jejunostomy. So what's the name of this procedure? This is known as Beger's procedure. So what's the name of this procedure? This is Beger's procedure, which is also known as duodenal preserving. Can you see? Duodenal preserving pancreatic head resection. And here you can see how we are going to perform the Fraze procedure. What's the full form of this Fraze procedure? It's also known as LRLPJ. LRLPJ, can you see here? I'm going to excoriate this duct, and after that I'm going to excise this pancreatic head, and then I restore the continuity of this duct along its whole length with jejunum. Can you see here? So here this continuity is restored, and simultaneously I'm going to excise the pancreatic head. So it is local resection of pancreatic head with longitudinal pancreaticojejunostomy. So these are the three procedures which are commonly asked in relation to chronic pancreatitis.